I think it's a little bit early to say it's the default strategy for all patients with symptomatic aortic stenosis. I don't think anyone's going to argue about the high-risk group. There's a lot of data for intermediate risk, and obviously there's the trials published last year in the low-risk group. So I think it is certainly the way we practice in a more elderly population, which are the vast majority of people who are going to present with symptomatic aortic stenosis. TAVI is a default strategy in the older age group. I think if we're going to look at evolving it into the truly low-risk population, the things that people are concerned about, certainly our surgeons are very concerned, is durability. We've got 12-month data. That's not long enough, especially when we start getting into younger age group. And of course, the low-risk trials, although they were a low-risk population, were actually elderly population over the age of 70. So I think really we'd need to look at durability and then looking at the younger profile patient. It's a little bit early, in my view, to extrapolate 12-month data that we have currently into all low-risk patients. Again, no, I think it would be a little early. I don't suspect there's going to be a huge outcome difference. There will be in certain, when you look at certain subgroups, pacing rates, etc. But as a generalisation, I think most of us feel that the valves work. They have their individual anatomical considerations, but they work well in the bulk of the population. But really, the evidence is only for two types of devices. And I think, again, extrapolating it out, particularly into the younger population, would be a little bit difficult. Well, generally, when we're looking at suitability for TAVI, it's actually the flip side of that. We're looking at the comorbidity or the frailty that actually makes them not suitable for surgery. So I think really it's appropriateness criteria. A young patient with relative low surgical risk, I feel at the moment you'd have to have quite a good reason why you wouldn't consider surgery for that patient. In the older population who are almost always comorbid and are often frail, it's a much simpler balance. And I think within the UK, certainly across much of Europe and the US, it's not a difficult decision either for the physician or the patient to consider TAVI as a good alternative, if not the default strategy for that patient. I think durability is certainly something that is of concern to a lot of people. Talking about durability in a 75 or an 80-year-old patient in whom ultimately, if you do have valve dysfunction, we can redo TAVI, valve in valve. It's not a huge issue. But if you're talking about putting a current TAVI device in a 40-year-old, we really don't have any data beyond about 10 years for those patients, simply because TAVI hasn't existed that long. So certainly our surgeons are very exercised about durability. There are reasons to consider that the TAVI durability might actually not be inferior to surgical valves, bioprosthetic valves, in terms of we tend to get a larger orifice area, and it certainly post-procedurally and within the short to medium term follow-up, we get lower gradients across that valve compared to a surgical bioprosthetic valve. So there are reasons to think durability isn't going to be the huge issue we think it might be, but it's still early to say based on 12-month data that we have currently available. You'll know that in the UK, Dan Blackman and his group in Leeds has done some data looking at UK experience, so we have got some data on durability out to 10 years. But of course, these are fairly small numbers of patients. But, that will evolve over time. And ultimately, if you need to redo a redo valve in valve, still, you could argue, is a lot less stress for the patient. in terms of the insult than redo surgery. So ultimately, although it certainly is a concern, it may not transpire to be the big issue we think it is.